Hello, welcome to the Kampala Advanced Trauma Care course. I am Cornelius Sendagire and I'm a cardiac anesthesiologist and intensivist at the Uganda Heart Institute and a lecturer at Makerere University College of Health Sciences in Uganda. In this talk, we are going to discuss airway management and we shall start off with a case scenario. A 22-year-old boda driver is brought in after crashing into a ditch. He had no helmet, smells of waraji, and has significant facial trauma. He responds only to painful stimuli. What next? In this talk, we are going to cover 5 goals. 1. To understand airway anatomy. 2. To recognize signs of airway obstruction. 3. To understand and demonstrate techniques for airway management. And 4. To understand scenarios that require establishment of a secure airway. And 5. To describe steps for rapid sequence intubation. When we perform primary survey, we assess, address, and reassess the ABCDE. We start with the A because that stands for the airway. Because we reassess, if there is any clinical change, we start back at the airway. Why? To understand this, we need to understand airway anatomy. What is the airway? The airway is the gateway to the lungs. The primary passage is through the nasal cavity to the nasopharynx, to the oropharynx, to the larynx, and then to the vocal cords, after which the air goes into the trachea and then into the bronchioles and to the alveoli. In some instances, for example during strenuous work, we use our mouths to breathe because then we are able to take in a lot of air to meet the need. At the laryngeal level, we find the epiglottis, a leaflet tissue structure connected to the base of the tongue that allows you to prevent aspiration when you swallow any substances. When we perform airway assessment, we start with assessment of the level of consciousness of a patient because if a patient is unconscious, the tongue is the first cause of airway obstruction. Inability to control the tongue is associated with the level of consciousness. So, we must quickly assess for airway patency and the level of arousal of a patient. We must look, listen, and feel. We look for signs of compromise, agitation or cyanosis, which may indicate hypoxemia, obtundation, which may indicate hypercarbia or increased carbon dioxide levels, accessory muscle use, paradoxical chest fall and abdominal rise with inspiration. Inspect the oropharynx for debris, blood, loose teeth, and deformities. Sucking chest wounds are also assessed. We listen for signs of compromise. We listen for a stridor, turbulence, snoring, all of which may indicate partial airway obstruction. Hoarseness of voice may indicate functional laryngeal obstruction. No air movement is often an alarm sign that indicates complete air obstruction and may be caused by multiple factors including pneumothorax or hemothorax. We feel for signs of compromise. Normally the trachea is located in the midline. However, in conditions such as pneumothorax, it may be displaced to the opposite side. We use the back of our hand because it's more sensitive than the palm, and even when we have gloves on, we can still feel for air movement. We feel for subcutaneous emphysema and broken ribs. One of the fundamental principles in airway trauma management is to assume that every patient who has been in an upper body traumatic incident may have a C-spine injury. We therefore must immobilize the C-spine, and we do this by performing inline manual stabilization, or what is called manual inline stabilization, which will be demonstrated later. It is important to remember that the neck collar doesn't adequately immobilize the neck, and thus the cervicospinal cord may still get injured. We use the cervical collar to identify an uncleared C-spine, so as to remove the helmet from a border driver, for example. This maneuver must be performed by two people. One performs manual inline stabilization while the other removes the helmet. A common cause of preventable perioperative death is loss of airway control. The commonest causes of airway obstruction can be categorized into three levels: the upper airway, the laryngeal level, and the lower airway. The commonest cause of upper airway obstruction is the tongue. The other causes include soft tissue edema, foreign body, and secretions. At the laryngeal level, laryngospasm and foreign body are the commonest. In the lower airways, the commonest is bronchospasms, edema, secretions, foreign bodies, and GI contents, or sometimes blood. Signs of airway obstruction are multiple. However, the commonest of them is inspiratory stridor, which may also be associated with paradoxical chest wall movement and abdominal movement, use of accessory muscles, tachypnea, tachycardia. Hypoxia is often a late sign of upper airway obstruction and therefore is an ominous sign. In order to treat airway obstruction, we must provide oxygen to the patient, clear the airway through oral suctioning or nasal suctioning. In case that does not help, then we can reposition the head by performing maneuvers like the chin lift and head tilt, the jaw thrust, or putting the patient in a recovery position. We may also use airway adjuncts like the nasal airway or the oropharyngeal airway, and we may also use continuous positive airway pressure. The chin lift requires one to put the fingers under the chin and then the other hand on the head. This maneuver is often performed with the head tilt. The mandible is displaced anteriorly, and this lifts the tongue off the base of the oropharynx. Because this maneuver allows you to extend the neck, it must be avoided in case of suspected C-spine injury. The jaw thrust is the other maneuver. Placement of two fingers behind the angle of the mandible on each side and displacing the mandible anteriorly will allow displacement of the tongue off the oropharyngeal bed. If done correctly, it does not extend the neck. It is important to use this procedure in patients with suspected C-spine injury to allow maintenance of cervical spine stabilization. The recovery position may also be appropriate, especially in patients in whom there is no suspicion of cervical spine injury, patients who are going to have long transport without monitoring, no airway personnel available to place a definitive airway, or absence or lack of airway adjuncts. The oropharyngeal airway, also called the oral airway or the Goodell's airway, is often placed in patients who have a low Glasgow Coma scale because it is a very uncomfortable device to place. An appropriate size device for each patient must be selected to avoid placing a very small or a very big device in the oral airway. The nasal airway, also called the nasopharyngeal airway, must first be lubricated, or you could use saliva in the mouth to perform lubrication. It must be appropriately sized, measuring from the nose to the earlobe, and must be placed gently avoiding trauma and bleeding. In case of open head injury, this device must not be placed in a patient. Head and neck trauma present special challenges like facial fractures, neck hematomas, and laryngeal edema. Facial fractures may prevent use of a face mask or performance of basic maneuvers like a chin lift or a jaw thrust. Neck hematomas and laryngeal edema may compromise the airway early on in the disease, requiring front of neck access. To perform oxygen delivery to any patient, multiple devices may be used. However, these are categorized into low flow devices and high flow devices. The nasal cannula delivers up to a maximum of 6 liters per minute. The oxygen it delivers is unpredictable because it's dependent on the minute ventilation of the patient as well as the nasal patency of the patient. However, to estimate the fraction of inspired oxygen delivered with each liter, we add 2% to 21% for every liter increase in flow. The simple face mask, or the Hudson mask, delivers flows from 5 liters to 10 liters. The least amount of oxygen that must be delivered with a simple face mask is 5 liters. It may deliver FiO2s up to 50%. The non-rebreather delivers perhaps the highest flows of oxygen of the 3 devices. It has a reservoir bag that allows delivery of sometimes up to 100% oxygen. However, this is still dependent on the patient's minute volume. You must make sure that the flow is high enough to prevent the bag from deflating with inspiration. In case this fails, then application of a self-inflating bag with an anesthesia mask and some positive airway pressure may relieve the obstruction in a spontaneously breathing patient. If no spontaneous effort, then the patient may be ventilated using the bag. Placement of the anesthesia mask onto the face requires a technique regarded as the CE maneuver that prevents you from compressing the soft tissue of the mandible. In case all these fail, then there may be indication for endotracheal intubation. However, there are 3 major indications for endotracheal intubation. 1, hypoventilation. In other words, the patient is not able to sustain their own breathing and therefore require assistance. 2, the patient fails to oxygenate despite conventional oxygen therapy available. 3, failure to protect the airway, especially for patients who have a reduced mental state. Often a GCS of less than 8 means that the patient is unable to protect their airway. Secretions or blood in the airway, direct trauma, including inhalation of burns, may be indications for endotracheal intubation. Whenever endotracheal intubation is needed, call for an experienced personnel to intubate must be made early in the course of the illness. Whenever endotracheal intubation is to be performed, visualization of the glottis, including the vocal cords, must be made prior to insertion of the endotracheal tube. There are 4 types of laryngoscopes that may be used. However, the commonly used one is the Macintosh blade. Performance of rapid sequence intubation requires achievement of 3 goals. 1, rapid achievement of unconsciousness, paralysis, and intubation. All this in order to avoid hypoxemia as well as ventilating the patient that may cause regurgitation due to stomach insufflation and therefore increase the risk of aspiration. To perform rapid sequence intubation, pre-oxygenation must be performed as the first step. This is to allow denitrogenation or in other words, removal of nitrogen from the lungs and increase the reservoir of oxygen within the lungs to prevent desaturation to less than 90%, especially when the patient is paralyzed. The patient may take 8 vital capacity breaths or breathe for 3 minutes at a high flow or high fraction of inspired oxygen, preferably 100%. It often takes healthy patients about 8 minutes before they desaturate to less than 90%, moderately ill about 5 minutes, and obese adults about 3 minutes. Rapid sequence intubation is often performed with assistance of cricoid pressure or a maneuver called Sellick's maneuver. This is believed to reduce the risk of aspiration by preventing regurgitation to the oropharynx that may cause aspiration. However, this maneuver has been under question in recent literature, and therefore it is vital to assess patients who are at most risk, for example, patients who have just had a traumatic incident, patients who have slow gastric emptying, like pregnant women or diabetic patients. Rapid sequence intubation is achieved with medication that achieve rapid unconsciousness as well as paralysis. Potential for reversal for a short duration in case of a difficult airway may be possible in some instances. Commonly used drugs include anesthetic drugs like propofol, ketamine, thiopental, etomidate. Paralytics include succinylcholine or rocuronium. C-spine stabilization must be maintained when performing intubation. However, there is limited evidence to prove its efficacy in protecting the spine. However, it is known that it is superior to using a cervical collar. It may, however, compromise the view of the larynx and compromise the outcomes of the spinal cord. We return to our case. A 22-year-old border driver is brought in after crashing into the ditch. He had no helmet, smells of waragi, and has significant facial trauma. He responds only to painful stimuli. Can you now figure out what next? Well, remain calm. Assess the airway. In case you suspect a C-spine injury, immediately place a cervical collar or perform manual inline stabilization after calling for help. If the airway is not patent, then perform a jaw thrust in case of a suspected C-spine injury. In case no C-spine injury is suspected, chin lift and head tilt are recommended. If this does not help, then you should be able to place an oropharyngeal airway or a nasopharyngeal airway in case there is no open head injury. Ensure to call for help early, especially in case you intend to have the patient intubated as soon as possible. You must assume that all patients have an unstable C-spine and a full stomach. For further reading, check traumaindex.org and the ASA. Thank you very much for listening.